Case number 6 is a 54-year-old white female accountant, 20 years of soft contact lens wear. Status post-LASIK 10 years ago. Type 2 diabetes. The patient complains of blur and fluctuation in vision and frustration doing her accounting on the computer. Eyes feel fine otherwise. And of course, this patient is seeking refractive surgery. On the exam, we see best corrected visual acuity 20/30 OD 20/40 OS. We look and we have central SPK. Now remember what the last thing this patient wanted was refractive surgery, right? Because they were frustrated with their contact lens. And so far has shown to be recalcitrant to conventional dry eye treatment. Had been on lifitegrast, 5%, BID for 2 years, cyclosporin, 0.9%. Again, looking at the mechanisms of delivery, so a cyclosporin that's going to be in a nanomicelle formula, so you know you're getting penetration to the surface. Had punctal plugs. This patient had been treated with amniotic membrane, but only resolves for 3 to 4 weeks and then regresses and returns right back to baseline. And yet this is somebody looking for refractive surgery.
Yeah, those are always my favorite, Doug, is that when you work in a cataract and refractive surgery center, that patients just think that all of their problems will be resolved by doing the LASIK or doing the PRK or SMILE or an EVO or clear lens extraction. I just want to impress you with all the different procedures I know.
So when we look at our case and we're saying it's recalcitrant to conventional dry eye treatment, lifitegrast, cyclosporin has failed, amniotic membranes, and the key to me is when this patient doesn't respond like they should to a cryopreserved amniotic membrane, what are we looking at next and what are we going to do? And on this patient, what are you going to do next?
Corneal sensitivity testing.
Corneal sensitivity testing, a must on this patient.
I am going to make a suggestion though. If you're going to use a cotton wisp, use gloves. Get some surgical gloves in your practice, especially any red eye you have in your practice, you want those gloves on because the transfer of the bacteria from your fingers to the tip there is potentially real. So, and also to me, it just validates it.
Yep.
So.
You see how you can get in between the lashes and you see the response on the left with this patient that has normal corneal sensitivity. You can go to the different regions real easily. And then on the right is going to be a patient without corneal sensitivity.
But how does that differentiate from a con-tip applicator?
It doesn't. It just
you said, see how I can do this with a dental floss versus not.
Well, because if you get a little strand of a cotton wisp and it hits the eyelash, they will respond, and that's a false.
Yes, true. Okay. That is true.
And so just because, and the other thing is, I have a very controlled amount where every cotton wisp is unique, like a snowflake. Mm-hmm. This is going to be consistent. If I have 1.25 inches of dental floss that I'm holding this, it's going to be a very consistent rigidity. So it's like a little bit of a control on being able to quantify it.
There was the neurotrophic keratitis study group, right? And they basically demonstrate that there's more like 7 stages as opposed to the 3 stages of the Mackie system, right? And I think part of the reason why neurotrophic keratitis has been so underdiagnosed is because we've always waited for that stage 3, between stage 2 to stage 3. But to your point, is that it didn't start that way.
Yeah.
And so you getting between 0 to 1. Or 0, to 1.5 is going to be really important for us.
Yeah, I think as a prognosticator of ocular surface complications and different ocular surface disease patterns, that corneal nerve health is going to play a very, very big role. But meanwhile, what we're doing right now is we're trying to detect, and I think that you're correct. Everybody looked at NK and said, that's a neurotrophic ulcer. And that didn't matter whether it was ophthalmologists or optometrists. That's how they would define it. And now we realize that we see all these different stages, and I completely agree with the study group's assessment of multiple stages of stage 1, multiple stages leading to 2 and through 2. Mm-hmm. But I think that early detection and what in that case history drives you to say, I got to test corneal sensitivity on this patient.
So it's interesting you say that. I mean, because of there's obviously genetic markers that would lead me towards that, like Mobius syndrome or just other genetic things that are rare. But diabetes, I mean, as we mentioned before, when we talked about that diabetic and how it slows down the oxygen production, and it really induces that neuropathy. I mean, it's like, I know we're Johnny on the spot to want to look into the retina, which is obviously Spanish for retina, to see if there's any diabetic retinopathy, but let's be honest, we got eye. So now we have to start thinking about corneal neuropathy. And so diabetic patients get a corneal sensitivity test in my practice.
You know, and that's absolutely profound, because what I've said with neurotrophic keratitis is, you mentioned some genetic disorders. There can be herpetic disorders, there can be zoster, there can be all kinds of things that we know, trauma, chemicals, things like that can cause neurotrophic keratitis. That does happen rather quickly.
Yep.
But what I would encourage all doctors is, when we look at this case study of saying they had LASIK, they wore contact lenses for 20 years, they have diabetes, don't look for the extraordinary, look for the ordinary that's in your practice every day.
Love that.
And that is, this patient with diabetes has had LASIK, has had contact lenses.
Right.
That's ordinary. Test the corneal sensitivity.
I almost feel like, the had LASIK is low-hanging fruit, because you've damaged the nerves a little bit. To me, just the biggest thing about this is that it's a patient who is symptomatic, but more importantly, is that diabetic. And also, I think the most cases that I think I've diagnosed have been patients with a herpetic component to it. Any time of zoster, patients who've had simplex, I've seen, and we know that it's affecting the nerves.
That brings up a great point, and that is, when you have an affected eye and a non-affected eye, corneal sensitivity testing is very easy.
Right.
Because it's affected, it's non-affected, it's normal, it's not normal.
Right.
Really easy to tell. What happens when you have a bilateral decrease because of contact lens wear, because of diabetes, because of corneal refractive procedures?
Yeah.
You need to get good at detecting what normal corneal sensitivity looks like, so that you can detect normal bilateral or abnormal bilateral when it starts to occur gradually. And that's where, I like the idea of looking at corneal nerve health, because then we're on a continuum.
Yeah. So you've diagnosed corneal sensitivity. You see that it's reduced. Maybe it's not zero, it's just lower. What are you gonna do?
Well, what I'm going to do at that point, I'm going to see, like in this case, what have they been on and what have they failed? Why are they recalcitrant? Well, now I have an answer why they're recalcitrant, because the corneal nerves are involved, which stops that afferent message to the brain, the efferent to the tear-producing glands, just like we looked in varenicline, how that connection is so imperative. And then I've looked at what they're failed, and then I'm going to look at something that will actually regenerate corneal nerve, and that would be a cryopreserved amniotic tissue. That's probably the first line that I would do. I'd see how they respond to that. They'd been on that. So what I would go is with Cernegimen at that point. It replicates human nerve growth factor, and to reestablish that. So depending on what they'd been on, but in this case, the patient had already failed on amniotic membranes, I would go right to ordering the Cernegimen for that patient. And it's an intense course.
Yeah. I'm a little bit more aggressive than you are, I think, which surprises me, because I find you to be very aggressive, which is why we're sitting so far apart from each other right now. But I feel like, again, is trying to circumvent something from getting worse and doing that preventative medicine. Whenever I see a decrease in corneal sensitivity, to me it's an aha moment. And my mindset is, we have one medication, we have one treatment. Patients love the notion of being, having an opportunity to change something. It's being unique, but they're also super concerned about costs and other concerns. And so to me, if you don't tell patients what to expect, then it becomes a complication, and then more importantly, especially like when you talk about cost or getting things approved and things. And Cernegimen does take a while, BKBJ, does take a while to get. So I will start those patients on an amniotic membrane, even if they've done it.
Oh yeah.
I will do it again
100%.
as a kind of a, almost just like a bridge gap, and let them know that I'm going to start them on the process.
Yeah, I 100% agree. And I just look at it as priming, doing everything we can in advance until we get it, because it could take a while to get that. Even if they failed, I said, we're going to do this again, because I want to give you the best head start we possibly can.
I tell patients a few things. One is, I say, look, I've detected something that I feel is important for us to manage. There's only one medication. Because it's rare, it's an extremely expensive medication, but you're worth it, and you're not going to pay for it. And I'm going to do everything I can for you to get it. And have you ever had a patient? I mean, I've never had a patient pay more than their copay.
No.
I mean, no. And I've prescribed dozens. Secondly, I tell them, look, when they call you, let them know you want financial assistance, because I think that'll help the process. Thirdly, is that when it does start to work, you're going to start to maybe feel a little sensation. And that to me is a positive. So there might be a little burning, there might be a little bit of irritation. So I bring those patients back at about 3 to 4 weeks into their treatment.
Same.
Just to see how they're getting along.
Same. The neurotrophic keratitis patient, especially when they're advanced, and I think ultimately we're probably going to be treating this at a much earlier state when we can really predict the prognostically where their corneal nerves are going and what the health is. But as we start that, it's a long treatment. But I don't have any patients, because they are so frustrated, that say, okay, no, I'm not going to do that. I'm not going to do a drop 6 times a day for 8 weeks. They're ready because they're afraid they were already at the end of the line.
Yep.
They were afraid there was nothing else that could be done for them. So I find that those patients, when you propose that, they're willing to do that. What's the conversation you have with them in terms of telling them what neurotrophic keratitis is?
So it depends on what the specific, if it was somebody who had a viral infection, then I'll say, the nerves were damaged, the virus basically, kind of coexisted or lived in the nerve, which is why you had that sensation. And now that nerve has basically been denuded or basically reduced. For my diabetic patients, over long-term time, the nerve basically started to lose its ability to function. The trophic nature of the nerve basically started to recede. And because of that, you're not getting the feedback you need. You're not keeping the eyes lubricated. The tissue on the outside of your eye is not differentiating. So we need to change that course. The other thing that's nice about Cernanogen is that, in their clinical study, and again, they evaluated patients that had stage 2 and stage 3.
Advanced.
Yeah, they had epithelial defects that did not heal. They had, ulcers that would not heal. And 80% of those patients after 1 year stayed healed. And
those are severe. Those are very, very severe. Now, when you're saying that, that's what they tested. It's still approved for recalcitrant PEK, stage 1, stage 2, and stage 3. So that's the beauty of that. What I tell patients, I'll say, because of what's gone on with your dry eye, what's gone on with your refractive surgery, what's gone on with your diabetes, whatever the case is, you have a downregulation of your corneal nerves. And what that means is the internet is down from your cornea to your brain. And so it can't get this message. Full credit. I got that from a doctor from Texas, don't remember his name, that said he uses that with patients all the time. I started using it. They get it immediately.
You find your language. You find that what's communicative to you that is going to resonate with your patients so that it becomes more digestible and understandable. Now, you start them on Cernanogen BKJ. What else are you going to do? Is that it? Do you just put them on that and call it a day?
No, I'm gonna continue their treatment. I'm also going to look for other underlying etiologies that may have supplied that, and they have it. And the diabetes is a huge one. That you look, and those patients might even have peripheral neuropathies, which they really know that, and they've certainly been advised that can happen when they have diabetes.
So one of the things that I've done, especially in refractive surgery, is I've always looked at from the perspective of that patients it's like, I tell them sometimes your vision's like a boat race. I go, and not only are you not, in first place, you're off course. So first things we might have to do is correct things to put you back in course. And then we're going to have to do other things to get you back in the race.
And it's a boat race.
Yes.
See, I would use airplanes, but you would use boats.
Airplanes, but that airplane's more scary because the ocean, at least. But my point being, though, is that it's like, we're doing one thing to set us up to be able to do something else.
Right.
Because I feel our profession just gets so hung up in and versus, or versus and.
Right.
And it's like, no, there's so many additive things we have to do.
You brought up a great question with the refractive surgery patient, and one of our questions from the audience is, how would you respond to the desire for more refractive surgery based on the history and science? What would you tell? I'm going to give you your explanation, because I know your explanation is going to be hard hitting.
Yeah, no, my explanation would be, are you crazy? Are you, what? No more, okay? Let it go. No, you know what? It's like those patients, and it's interesting because those patients sometimes are referred in by optometrists You know, this person had LASIK, this person wants to have an enhancement. My staff in my office knows that there is no such thing as an enhancement evaluation. It's a comprehensive eye exam.
Right.
And so what I will do at that moment is say, you know, as much as I would love to be able to correct your vision, this hopefully is going to stabilize the quality of your vision, and then we can reassess it afterwards. But at that age, we're talking lens replacement anyway.
Yeah.
And so it's really getting people away from the notion of more corneal refractive surgery.
And a lot of times, this patient is unhappy because what they feel has been something that does not exist, which is regression of their refractive surgery. And it's actually the dryness that has happened from the neurotrophic keratitis that is causing their frustration. And I'll tell them, your problems will be multiplied by 10 if we do some more refractive surgery on you. Move it along. Anything else you want to say about neurotrophic keratitis?
No, you know what? The only thing that I want to say about it is that don't be afraid of it. I mean, it's way more common in your practice. And once you see it, it's one of those things where you just start thinking about it and dealing with it more.
Look for the ordinary,
Call your
not the
Dompe.
extraordinary.
Love it.